This chapter will be an introduction into the four main types of choroidal and subretinal neovascularization. I try to remember the numbers associated with the neovascular membranes as they go from deep to superficial and then back again to the choroid. Type 1 used to be called occult. We knew the membrane was there clinically because of hemorrhaging and edema, and angiographically because of hyperfluorescence and leakage. But we could not visualize the extent of the membranes because they are under the RPE, thus the original term occult. Here are some diagrams taken from the Macular Disease Atlas of Dr. Don Gass. Figure A shows just the beginnings of the neovascular net growing under the retinal pigment epithelium. Figure B shows more proliferation, and C shows the exudation of fluid from the neovascular membrane and the elevation of the RPE. This patient complained of distorted vision in his right eye. Here are some photographs of his occult membrane. Clinically, there's RPE modeling, and at the slit lamp, some subretinal fluid was noted. At this time, however, there was no hemorrhage. The fluorescein angiogram shows early hyperfluorescence, which then grows in the later phases of the angiogram. The edges are diffuse and they're not sharp, and you'd be hard-pressed to say exactly where the edges of the neovascular membrane end. Here is another example of a type 1 choroidal neovascular membrane. This is a 76-year-old gentleman with 3 weeks of distortion in the right eye. His vision was 20/150. 6 months previously, his vision was 20/60 due to dry macular changes. The arrows on the early angiogram superiorly point to diffuse hyperfluorescence. You can note there are multiple areas and not one single spot. On the inferior angiogram, the late angiogram, the arrow points to an area of hyperfluorescence that did not light up early on. The question is, does the choroidal neovascular membrane extend to this lower arrow or does it not? That is a difficult call, and therefore you can see why this patient could not be treated with laser as in the macular photocoagulation study protocol. So this is why so many people with age-related degeneration could not be treated with laser, why we kept looking for another treatment. Here's our final example of a type 1 or occult choroidal neovascular membrane. This patient had good vision at 20/20, but complained of distorted vision. Clinically, the macula looked fairly good, and you can see there's no pigment migration and there are no drusen. The fluorescein angiogram shows a different story. There's hyperfluorescence and leakage superior and supratemporal to the fovea. This is very typical of a type 1 choroidal neovascular membrane. For confirmation, we did an OCTA. The OCT shows an irregularly elevated RPE and subretinal fluid and shaggy photoreceptors. The OCTA shows the neovascular net in the choriocapillaris. And that confirms the diagnosis of an occult or type 1 choroidal neovascular membrane. Type 2 choroidal neovascular membranes are actually subretinal as they are above the retinal pigment epithelium, and the older term was classic. It was called classic because the angiographic findings showed a very well-defined choroidal neovascular membrane. Because type 2 choroidal neovascularization is above the retinal pigment epithelium and in the subneurosensory space, it therefore must grow through a break in Bruch's membrane. The top figure is again from the gas atlas. It depicts the neovascular net growing in the subneurosensory space. Note the black arrow that points to some abnormal retinal pigment epithelium. The bottom photomicrograph is one of a neovascular membrane. Note the proliferation of the RPE under the net and growing around the leading edge of the membrane. This is a 90-year-old gentleman who has had decreased vision in the left eye for 7 months. His vision is only count fingers. There is a gray-green hue to the central macula, and this is a typical color of a classic choroidal neovascular membrane. There's also loss of choroidal markings centrally secondary to the edema. You can see faint hemorrhages at the leading edge of the choroidal neovascular membrane superiorly and supratemporally. His fluorescein angiogram is an example of a type 2 neovascular membrane. The photograph highlights many of the classic angiographic findings of this type of membrane. First, note the origin of the net. The arrow points to that. Then, note the spoke-like pattern growing from the source out to the leading edges. While you can see the spoke-like vessels, they do not leak as much as the leading edges. This is because the spoke vessels are a bit more mature than the leading edges, and they've developed some tight junctions so they don't leak as much. The leading edge has very immature vessels, and they are hyperfluorescent, and they leak because they do not have tight junctions. Finally, note the dark area at the leading edge. This is where the pigment epithelium is wrapping around the leading edge, which you saw schematically and on the photomicrograph on the last slide. Now, life is not always so simple and straightforward and clean-cut. Sometimes there's a combination of a type 1 and type 2 choroidal neovascular membrane in the same patient. This is a 65-year-old who had previously been followed elsewhere for chronic central serous. His vision was gradually getting worse over the past year. The vision in the right eye was 20/60 and the left eye 3/200. Note the retinal pigment epithelial changes centrally in both eyes. Now, please don't get me wrong. I'm not inferring the prior doc made a misdiagnosis, and I will refer you to my chapter on central serous choroidopathy in patients over 50. Very, very difficult, and this patient could easily have converted from one to the other. Here is the OCT of this patient's right eye. The white arrows are going from left to right, show subretinal fluid, a double layer sign, and Bruch's membrane. The OCTA shows the neovascular membrane in the choriocapillaris area. Here's the OCTA of his left eye, and it's much more dramatic, with the double layer sign, fluid under the retina, and intraretinal cysts. The OCTA shows blood vessels both in the choriocapillaris layer and also in the subretinal space in the outer retina. So this patient has a combined net both of a type 1 and a type 2. Type 3 choroidal neovascularization starts a little bit more anterior than type 1 and 2 because it starts in the retinal capillary system. And the blood vessels grow posteriorly. It connects with the choroidal vasculature. This is a 77-year-old man He has no light perception in the right eye from an old chronic retinal detachment. He has had a rapid blur in the left eye for 2 months. Previously, the vision was 20/20, and it is now recorded at 2100. Note the central light retinal pigment epithelium, and this is from a pigment epithelial detachment, which is oftentimes goes along with the type 3 choroidal neovascular membrane. Also, notice there is a superficial hemorrhage centrally. Superficial hemorrhages are a hallmark to type 3 choroidal neovascular membranes. This is a fairly typical angiogram of someone with the type 3 choroidal neovascular membrane. You can see the hot spot centrally, and this is the intraretinal neovascular complex. There's also some blockage both from the hemorrhage and some pigment. There's a well-defined area of hyperfluorescence, and this is from the pigment epithelial detachment. The OCT of this patient obviously shows the very prominent pigment epithelial detachment under the fovea. There are some intraretinal cysts, a little bit of subretinal fluid at the edges, which is more of draping rather than actual fluid. And then the arrow on the bottom shows the neovascular complex. The patient was started on monthly anti-VEGF treatments, and several years after the first diagnosis, the PED has flattened. He's able to retain his vision at about 20/80 because the atrophy is just temporal to the fovea, and the fovea is yet uninvolved with the area of atrophy. The pigment is down, and there's no hemorrhaging at this time, and he's maintained the vision for many years with regular injections. This OCT was taken at the time of the last photograph. You can see that the PED has flattened. There's atrophy of the pigment epithelium, but he still has some neovascularization in the choroid. To summarize, retinal angiomatous proliferation occurs in about 10% of patients who have the wet age-related macular degeneration. Dr. Iannuzzi has described different stages. The first one is proliferation of abnormal blood vessels in the deep retinal plexus. Stage 2, the neovascularization grows into the subretinal space, and they may have a pigment epithelial detachment, superficial hemorrhages, and exudates, and that is the example that we just showed. Stage 3 is a vascularized pigment epithelial detachment with retinal choroidal anastomosis. There are specific differences between a RAP lesion and someone from a classic choroidal neovascular membrane. With the type 3 choroidal neovascular membrane, there are intraretinal and superficial hemorrhages. With the neovascular macular degeneration, they tend to be subretinal. Also, the type 3 membranes oftentimes will have hard exudates, and these are not a classic finding in type 1 and type 2 membranes. Also, many of the lesions are not in the fovea because they are arising from the capillary plexus, and you don't have that right in the fovea. And then also, there's also a retinal pigment epithelial detachment. Our final example is type 4 choroidal neovascularization or polypoidal. And I'll just give an example here, but it will be expounded on in later chapters. This is a 46-year-old African-American female who's had decreased vision in the right eye for several days. The vision was recorded at 2150. You can see the prominent portion of this is the subretinal pigment epithelial hemorrhage, that deep purple hemorrhage inferiorly. There's also subretinal fluid extending through the fovea and into the superior macula. The fluorescein angiogram shows not only blockage from the hemorrhage, but also multiple areas of hyperfluorescence from the polypoidal lesions. The type 4 choroidal neovascular membranes generally have hemorrhagic retinal pigment epithelial detachments, and they're about maybe 4 to 9% of all of our exudative degenerative patients. The ICG is definitive for making the diagnosis to find the polyps. Treatment has a variable response to anti-VEGF, and many times it is combined with photodynamic therapy.